the way that I think perhaps global health or global surgery is done badly at times, including by myself. But it's not a criticism of any one program because there's so many ways of doing this. So uh, this is me in the middle there with the curly hair as a I think I don't know, not sure, 3 or 4 year old. And I grew up in a Christian family and went to an all girls high school. That's my mum and dad there in the corner. Went to an all girls high school. The motto was faith with fortitude, and so we were all supposed to go out into the world and do good. And I guess as a young woman and a high school student, I probably thought that I might grow up to be a cross between Mother Teresa and Albert Schweitzer. A general idea that I wanted to help people in the world. So I had an upbringing that kind of led me to have an outward looking view. Um, so when I was a fourth year medical student, so that's age 21, I had barely been outside of Australia. I think I'd been to New Zealand and Fiji, which is not particularly different to where I was living. And I was at church one day, and someone was giving a talk, and they said, "Oh, there's this clinic in Bangalore," and this is Bangalore pre-tech, so a much smaller town than what it is now, the thriving metropolis it is now. Um, and there's a clinic in Bangalore and they don't have a doctor. And so if anyone knows of anyone who could go there for a little while, then why don't you go? So, of course, as only a very brave 21-year-old can, I put up my hand and said, oh, I could go. And so with really absolutely no background knowledge of anything to do with where I was going, or what the disease patterns were, where I was going to be, or anything, I went from Sydney to Bangalore in 1986. So, look, this was, in my life, a seminal experience. Top right is the clinic that I worked in, and some of the people that I worked with. Top left and bottom left is the health workers that I worked with, and there I am in my incredibly culturally sensitive Foster's beer t-shirt, working with the health workers, and of course doing a little bit of medicine, but really I was completely untrained for this situation. And we know that a lot of medical students, their first experience is possibly something that really is a lot more about them than it is about anyone else. So this young boy here is Victor. Obviously, any photos that I have permission to use. So this young boy here is Victor, and this was such a important time in my life that I really kept in contact with some of the people I met there. So that's Victor at 3 and Victor at 33, and we kept in touch over the years, and I've been back to Bangalore many times, and stayed really in constant contact with this family that I met there. So obviously a very important event in my life, and it made me think that here I was contributing to global health. But really, when you look at probably the impact in terms of health, it had a very social impact in terms of me and my friendships. But when I looked at the impact in terms of health, probably I really contributed very little. So I continued to sort of look for opportunities and be drawn to things. This is Kohima in northeastern India, in Nagaland, where I happened to meet someone in Melbourne who was from Kohima, and she said, "Why don't you come on up and come on up and do some lectures and speak to some of the doctors up there." At least by this stage, I was actually a neurosurgeon, and so I had some skills. I wasn't just a medical student, so I went and gave some lectures. This is a view around Kohima, and one of the talks that I was giving, someone ran into the back of the lecture theatre and they said, "Quick, quick! You've got to come to emergency." So, okay, I went to emergency, and there was this man who had been thrown out of a granite truck onto a rock at the side of the road and had a CT scan that showed this compound depressed skull fracture. So I said, oh, okay, well, what are you going to do? And they're like, well, we're going to elevate the fracture. And I'm like, great, that's what you're going to do. Do you know how to do that? And they're like, no. And they're like, could you come and help us? And I'm like, sure. So anyway, I went along. There I am operating. This was in Dimapur, operating on this nice man, Mr. Ganesha. And we put that all back together again and made it all look extremely nice. And the patient did very well. But of course, what I realized later is that, number one, I used a whole lot of instruments and plates and everything else that was pretty much the hospital's whole supply for the year. And that the way I did the surgery had a lot of financial implications for the patient. And if I had have had a better understanding of what I was doing, I could have done this surgery in a way that was much more sensitive to the local needs and to the needs of this patient. So learning all along the way. Sorry about the gory pictures. That's the end of the gory pictures. But this is my friend. Nitsa, who is so the friend I was visiting in Kohima, and her mum and her grandmother. And again, lifelong friendships made through this sort of passion for global health, but not super sure that as yet that I'd found that I was doing something that was actually useful. So next episode was, by this stage I was a trained neurosurgeon. I think it was around 2008, 2009, working, and the magazine that my surgical college puts out, it's called Surgical News, had a little ad in it saying teachers wanted for global health program in Rwanda. So I looked over the top of the little comic at my husband and said, oh, do you want to go to Rwanda? And he's like, oh, well, I've never seen the gorillas. So we thought, okay, we'll go to Rwanda. That was our great motivation. We wanted to trek with the gorillas. And as you can see here from this photo, yes, we definitely did trek with the gorillas. So this was with an organisation that no longer exists called Specialists Without Borders. It was an Australian organisation that was supposed to meet needs through medical education. So this, again, I went back for a few years, and this is in 2010. And the way that we did our medical education was in this lecture hall, very much like any other regular conference. And it was basically a series of lectures. And, we all sat over here on the left, and I'm kind of sitting there in some of these lectures, looking at how engaged people are, looking at what we're really achieving. And of course, Rwanda's French speaking, so we don't speak French. So number one, probably not an appropriate method of presentation. And number two, I just don't think that we were getting any messages across because our Australian English, so we weren't contextualized, and our Australian English was very difficult for everyone to understand, and their French and Rwandese accented English was very difficult for us to understand. And so I thought that these lectures were probably not really achieving anything. However, when we moved into small group teaching, this is when I suddenly saw people like really leaning in. It didn't have to be around the bedside. We did some bedside teaching, but we also did small group teaching. Things like how to examine an injured shoulder, how to do a neurological examination. These sorts of things that were in small groups with, maybe 6 to 10 people. We had time to interact, ask questions, learn exactly what our learners knew, exactly what they needed to know. And so at that point, I really felt that education was the most important aspect of what we were doing, and that there were better ways of doing it than what we had been doing. And of course, while I was there, there's so many other things that are shaping the idea that what we need to do needs to be contextualized. I met this little girl who, by a group from overseas, had a tracheostomy put in, and of course that is unable to be cared for anywhere in the community, and so she basically lived in the hospital grounds. And I'm not thinking that was the best way for her to have been managed. And then in every hospital in Africa, as the people online here well knows, there's so much donated equipment that is, donated inappropriately or without a service contract, or without, any number of things that would make it actually useful from all sorts of well-meaning places over the world. And so I kind of felt like we needed to get this right. We needed to really, if we were going to be doing any sort of aid, then or any sort of activity in global health, we needed to get it right. And that's particularly because the places I went, I had no context as to how things were done normally. I met these fantastic health professionals who were obviously providing, very high level care for the situations that they were in. And so I needed to learn how to partner and be appropriate in that situation, rather than just feel like I was coming in and imparting knowledge, which obviously is not always the best thing. And just another great example of the aid, these fantastic ambulances given. I think this is in Malawi. Ambulances given, but with no ability to have new tires. So there they sat for a long, long time. So I had the opportunity to take over Specialists Without Borders, which we didn't like the name because it really wasn't anything to do with Doctors Without Borders. It was sort of just tacked on. And because specialist is a very Australian term for a senior doctor. So we thought, well, it doesn't really cover what we do. So we changed our name to Pangea Global Health Education. And I'll tell you why. And our vision is to deliver the most effective health education in the world. That doesn't mean any particular type of health education. It could be any level. The idea is to be where you are needed, where you can be helpful, not where you want to go. So the reason that we chose Pangea for the name is because in the original continent, Miami and Freetown were right next to each other. But then when the original continent broke up into the world as we see it today, obviously, if you live in Miami by an accident of tectonics, you get to live like that with healthcare like that. And if you live in Freetown, you get to live very differently and with healthcare, which is very different. So we thought that Pangea was the idea that we could try and bring standards to be similar, work towards similar standards by providing health education. And I've already got that. And we thought we probably filled a niche where, there's all sorts of ways of giving global health interventions that are either mobile or static and direct or indirect. And, so the sorts of things that are direct care and static is a hospital. The sorts of things that are mobile, giving direct care, are the big NGOs that go around giving care. Static and indirect, which is teaching and learning, is universities. And Pangea thought we could be mobile and mobile teachers and learners, which really put us in a little niche. So this is one of our typical groups. So we now teach largely in Malawi, although recently we've been invited to the Thai-Myanmar border, which is where we've delivered another program, and we hope that will be long-term. So this is a multidisciplinary group, and we teach across nurses, doctors and clinical officers, medical students, and biomedical engineers. So the medical students are taught by junior doctors because and the rule is if you can't do it in Australia, you can't do it anywhere else. So we don't have junior doctors teaching to people who they wouldn't normally be able to teach in Australia. So we take a group of senior doctors who teach across all the programs, a group of senior nurses who teach across the nursing programs. We take the junior doctors teach the medical students and biomedical engineers, and just as a sort of and the teaching is critical care and surgical. That's really our focus. We don't have any infectious disease specialists, but surgery, obstetrics, trauma, anesthesia, anything that goes around surgery and critical care. So just to give you a sort of a general idea of the sorts of people we take, this lady's a renal physician who specialises in perinatal medicine, breast surgeon, ENT surgeon, anaesthetist hiding behind there, neurologists for management of acute conditions like seizures. We've got in the middle across here nurses, all 4 nurses. We take some medical students. They obviously can't teach, but they run logistics, serve the food, print the paper, make sure that the cats are herded to the next place. So we've got pediatrics, cardiothoracics, neurosurgery, general surgery, and overall we can really mostly cover the breadth of surgery and critical care. So our idea is that our teaching is, and of course we don't always get it right, but our teaching is flexible, customised and sustainable, and in partnership with local health professionals. And that's really something that we've been aiming for, because, this idea of a bunch of largely white Australians turning up somewhere to do some teaching is obviously not the ideal model. And the partnerships are both important to build local capacity, but also for us to learn what is the right way to be turning up in the place that we go to. I think you go to a place once and do everything wrong, and then develop relationships. That means that you can actually start doing a good job. So you can sort of see here, obviously, often where we are, there are not a lot of teaching spaces. So, we're very happy to teach on the floor or outside under a tree with our laptop on our laps. We use low-tech models. This is an airway, a surgical airway model that we make with some equipment that's just lying around any anaesthetic room in Australia. We do take some mannequins and we use, local. So this is a goat, some locally sourced things to be able to do the teaching that we do. So it doesn't cost a lot of money. Every person who comes pays their own way. So Pangea does not pay airfares, accommodation, or anything for the teachers. They pay their own way, except for we have a small group of nurses who come every year. And so we pay them a small stipend to help cover their airfare, because, for nurses on a nursing wage to come to fly to Africa every year is quite a significant financial hit. So we do, for nurses who've come more than once, they have the first time they come, they have to pay it their own way. But if they come more than once, then they do get a small stipend. So our teaching is small group, case-based, practical skills-based, and really we try and make it as relevant to the participants. So, we turn up with a published program, and then we ask what is needed in our first meetings together. And then we can change everything depending on what people want. So if there's been a particular need for a certain kind of teaching, then we'll change our program or add something in. And of course, as you would all know, the things that are most requested, so we know now what's really needed is trauma, head injury, spinal injury, burns, orthopedic and abdominal emergencies, and obstetric emergencies and pediatric emergencies. So, but on our first day, we give everyone who's attending a piece of paper. We ask them to write down 3 things that they would most like to hear. in the seminar series, and for which usually runs over 3 or 4 days, and we will try, if we have any expertise in the areas that are requested, we will try and give some teaching on that. As I said, very multidisciplinary across, for medical students, simple suturing to chest drain insertion, to various resuscitations. So very, very broad across what we teach. We try and make it fun. None of our teaching is actually sitting around just listening to someone talk. It's all very practical. This here I've put in, this is the dermatome dance. So when we're for instance, when we're teaching spinal injuries, we've made up a dance that allows you to remember very easily the dermatomes that you need to know as the levels of the spinal injury. So we try and make everything interactive and a lot of fun. So this is just these are all very amateur videos, but just showing at any one time what our seminars might look like. So this is obviously obstetric teaching. That's petunia the pelvis. That's one of the models that we take. But this is what it might look like. So small groups, taking whatever teaching spaces we can get. That was neurology back there. This is teaching in neurosurgery. This is airway, ear, nose, and throat. And I think at the end here we've got neonatal resuscitation. So those would be lectures that might be 30 minutes or 35 minutes, and then people will move through, and we help try and get people to be doing the topics that are useful to them. And every year we refine it to make sure that we're not subjecting people to stuff they don't know, and that we are imparting stuff that they'd want to know. And sorry, like I said, we try and make it fun. So I told you about the surgical airway model that we use, that you can see on the table here, and we really try and make this fun by having what we call airway races, so everyone can win a prize. So the first to get the surgical airway in with a bougie and a tube wins a prize. So we always have a lot of fun. And just one more video. We try and add a few surprises into our teaching. So this starts out looking like a very boring lecture on burns. So that's obviously someone made up to look like they've got burns with an airway burn. They've got large burns on the back of their shirt. Participants have to resuscitate him, roll him over, work out where the burns are, do a calculation. So we try and make the teaching as interesting and as fun as possible. So yeah, you can just see a few more pictures that of what we do. So over this kind of journey, I'm in amongst surgeons all the time, and I meet a lot of surgeons who might go and go to somewhere in the world, really just as sort of what has come to be known as surgical tourism. They do one mission trip and have a great time, obviously, but that's more about the person delivering the care than the person receiving the care. And I think it's also very particularly for surgeons, because we really have a contract with a single patient, and that's how we tend to work. We sort of have a really patient-centered approach, so it's about the person in front of us. It's about a single person, and that's fine. That's great for the person, but it does little to improve medical care for the population. In fact, it can probably even set it backwards, can even be harmful. So I think when surgeons think about doing global health or global aid, really they need to think about a different way. So how do we do global neurosurgery, global surgery, global health, whatever you're doing well? It's pretty much, I know you guys know this, program designed around the trainers, not around the trainees, not the trainers. For surgeons, it's about much more than a procedure. Now, I know there's some really fantastic programs that are about a procedure, but I think that's a very specific subset. Something like cleft lip and palate can be very, very easily done, one and done. It really changes someone's life, and then sort of move on. Endoscopic third ventriculostomy maybe in some ways is like that. But it really has to be more than just about surgery. And in fact, what I've learned from most of my colleagues in Africa, they know how to do the procedure in their own setting as well as anyone. I don't need to teach them how to operate. It's a whole bunch of other skills that I can impart. You need to do a needs assessment before you start doing anything. Relationships and partnerships are critical, and I'll talk about that in a minute. It's got to be long-term investment. Going to somewhere once is just not going to make any difference. Infrastructure and workforce are probably the most important considerations in anywhere that you are. It has to be capacity building and a culture of mutual learning and continuous feedback. And there's avoiding the racist stereotypes that we know are everywhere in global aid. So here are the partnerships that have, this is Godfrey Maguti. He's a professor, was a professor of surgery in Zimbabwe, and I knew him for many years, and so that really informed our program in Zimbabwe. And Nyango Mkandawire, who's an orthopedic surgeon, and now I think he's the head of everything medical school or everything in Malawi. And it was those partnerships that meant we were invited to go. So we knew that we had support when we were there. We had some context as to what would be helpful in advance, and that allowed us to grow these long-term partnerships, and with their support allowed us to be successful. And then there's other sorts of partnerships, which is trying to bring the people who we are visiting into our teaching. So now 50% of our teachers in the junior doctor program who teach medical students in Malawi are Malawian junior doctors, and this is Florence and Vintenga. They were our first junior doctor teachers, but it's great now, and we're lining up to go in September, and we have 37 local applications to teach alongside us. And then just the idea that you start seeing people who you met. So this is Ken Keller Kumwenda. He's a neurosurgeon whom we first met as a medical student in one of our early programs, who now is a neurosurgeon in Lilongwe, and watching that journey and having that long-term partnership, and me learning a lot about neurosurgery in ways that I didn't imagine have been key. So I've come to the conclusion, as much as I'd love to go and operate, because that's what we do, that's what we love, I really think that education should be the primary focus of global neurosurgery, global surgery. This talk was written for a global neurosurgery forum, but just take the neurosurgery out and make it surgery or health or whatever you like. It reduces ethical conflicts. It tries to avoid local disempowerment, reduces inappropriate treatment of individuals. It reduces wasteful efforts. It promotes local culture-driven healthcare, and it's about more than a procedure. So thank you very much. I'm very happy to discuss or take any questions. And thanks so much for having me.
Thank
Amazing.
you so much, Dr. Drummond. Um, so now we'll invite the participants to either put your questions in the chat or raise your hand so you can unmute yourself and ask Dr. Drummond your question directly. Any questions?
Yes, we have a question from Igdalia. Igdalia, if you want to come off mute and you can ask your question.
Hi, yes, I can ask that. So thank you very much for the talk, Dr. Drummond. It was really great learning from your experience. My question is particularly with respect to the global health education, right? Education initiatives. So I wanted to
Mm-hmm.
ask what advice, based on your experience in global health education, what advice you have for groups or people who are working on similar education initiatives, perhaps certain challenges that you faced or certain things that you think they should take note of even as they design such educational initiatives. It could be in form of courses or any kind of initiative like that. Thank you.
Yeah, I mean, I think we've learnt as we went along, and I think the really key um, points is having someone who can give you local context, um, doing a needs assessment of what what the what the program should be achieving with your learners and also with people around them. So, for instance, if you were teaching a group of junior doctors, taking a needs assessment not just from them but from the people who are training them. Um, Thinking about how you can best teach a topic. I think we tend to just think, okay, we'll give lectures, or you know that we can impart knowledge by just giving lectures. But we've all sat in a full day of lectures and lost the will to live after about 10:30 a.m. So thinking about how is this better taught as a lecture? And we do lectures to sort of bring everyone together, but is it better taught as a small group? Is it better taught um, with a model? Is it better, is it better taught as a case based? And so just trying to make the whole day interactive and remembering that, the thing we have to do a lot with our teachers is to say that, well, for each little lesson that you give, you can only impart three facts. No one remembers more than three facts. So to pair it right back to what's essential and to make it really interactive and useful. That's what we've found. And that's true in Australia. I mean, that's not about even global health. That's how to do education well in wherever you are.
Great. Thank you very much.
Amazing. Thank you. Do we have any further questions?
While we're waiting, I just have just to sort of like follow up to that question. I can imagine that, I mean, in your uh, work, you've had to, work with people from various backgrounds. And I'm wondering if in the process you faced any challenges arising from, conflict in or arising from this differences in backgrounds. So, for instance, from where you're from, Australia to, um, you know, people in Africa, were there any sort of challenges that you faced? Perhaps the fact that, people saw certain things differently, and the like, and how did you navigate such challenges?
Oh, all the time. And yeah, that's why I say that, partnerships are critical. Being invited is critical, so that you can, you have context. And it's always been our fault. It's always been that we haven't understood something So a very simple example is, perhaps one of our less experienced teachers mentioning something that is, or teaching about something that would be entirely inappropriate in the situation that we're in. For instance, talking about intubating a sick child, where that would not be what would happen locally. And then that being sort of discussed in other forums, and the teachers of the other teachers of those people coming and saying, hey, look, you can't teach that this child needs to be intubated because that's not what we would do here. It would create enormous social problems. Please don't do that. And so us having to learn. There's sometimes been some, inappropriate interactions. You've got a whole bunch of boys and a whole bunch of girls all in the same place, and, misunderstandings with regards to people's intentions. So all of those things, you just have to navigate them with good grace, with talking it out, and basically with learning that it's always our fault. We're the visitors. We're the people who are not are causing the problem, and to try and make that right.
Thank you very much. I think I particularly could resonate with, the fact that oftentimes, education or such initiatives should be thought of more as collaboration. And I think that's something that, we have learned even very early on here in Mission Brain. And it's something that our Dr. Q says very often, and our leaders here, that, it's collaboration, and we're not just going to teach, but we're also going to learn, because everyone has something to bring to the table. And I think that sort of humility is what is very crucial if we're going to have exchanges that will move every party forward. Thank you very much for your insights.
I think there's someone called Peter who's got his hand up.
Yes, go ahead, Peter Anu. Thank you so much, Igdalia. You're muted, Peter. Oh, there.
Hello, good evening, Prof. Thank you for a very, very interesting and inspiring lecture. And I want to ask a question, because most of what the lecture series covered is the role of the professors or consultants and the junior doctors who are offering services in foreign places where the customs are different. And then you talked about the importance of collaboration and then understanding context and social norms. So my question is, for people like medical students that are still in training and stuff like that, how do medical students be a part of this? How do we ensure that we are playing our part in making sure that education in global neurosurgery or global healthcare is going as well as it should? Because it's important that it goes well and then we play our part too, because after you all, it's all up to us to keep the flag high. Thank you so much.
Yeah. I mean, the way we try and do it in Pangea is we try and take some medical students with us each year. That's not because they can teach, but they do have very real jobs in the organisation to do all the logistics of the program, and that is really has been really great to mentor people into Pangea in later times. So, for instance, Heidi McAlpine, who's just about to qualify as a neurosurgeon, she's been running our program for junior doctors teaching medical students. She started out as a medical student in our program, and then moved through that program to now be in charge of a whole part of the program. So having medical students involved early in things that they are qualified to do is important. And then back in Australia, we have a very active group of medical students who undertake fundraising and help us out with various projects. So I think if, as a medical student, if you want to get involved, it's just that. pick something that you think is a good organisation doing good work, and say, okay, how can I get involved now? Because pretty soon I'm going to have the skills to be involved more.
Um, Thank you so much. Well, the organization I have chosen right now is Pangea because what you guys really do over here is is really, really amazing, and there's so much love that goes into it, and I would really want to be a part of it and do what I can from my very tiny corner in the world to make the world a better place.
Well, I should have had our website up there. Get onto our website, www.pangeaghe.com. So Pangea Global Health Education.com. And contact me through there. And we can keep in contact with you and let them know that you heard me on the webinar, and we can keep in contact, Peter.
Okay. Thank you so much, Doctor.
Okay, there's a question in the chat. Hello, doctor. I'm curious as to how you would be doing a needs assessment, especially done in partner. Yes. So how to do a needs assessment. So for us, it's not always been a super formal process, but it has been, as you mentioned there, discussing with the partners what would be useful. So, we're going into a situation where getting some background. We always do some reading on the healthcare system. So we do. So let me formalise it. We do some reading in Australia about the healthcare system, about what where we're going is like, how things are funded, how what the norms are. There's always a lot of literature on the internet about wherever we're going. We speak to the people who have invited us, because obviously that's a very good source of information. And then we do constant feedback from our participants. So at the beginning of each program, we ask people what they would like to learn. So that's a bit of a needs assessment. And in fact, that has informed our program a lot, because the same topics keep coming up. So we certainly concentrate on head injury, on spinal injury, on burns, on pediatric emergencies. These are things that come up every time we ask people what they want to learn. So that's really helped us. And then we do feedback, and we do feedback on each of our lectures, on each of our teachers. I have lots of tricks of getting feedback. For instance, no one gets lunch until they've shown me that they've filled out their form or done their feedback. So no form, no food. And so we get detailed feedback from all of our participants, and that is an ongoing needs assessment that then helps us to design our courses. I mean, sometimes there's just things that we can't do or can't fix, but that really helps.
Thank you so much, Dr. Drummond, for that amazing answer. And we also have Alucine, who has a question here. Alucine, if you can come off mute and ask your question, please.
Yeah, hello. How are you?
Good. How are you?
Yeah, I'm Alucine, a nurse from Sierra Leone, one of the new trauma care nurses in Sierra Leone. I'm just curious. And what are the most practical low-cost intervention that can improve outcomes for patients with glioma in developing countries?
Yeah, that's really, really problematic. I mean, I really struggle with this. I mean, there's not really, number one, it's as you know, always a fatal disease. So, that's I guess something that has to be factored in with any intervention. The mainstays of treatment for glioma are surgery, radiotherapy, and chemotherapy, but in reality, they almost need to be delivered together. Radiotherapy is probably the most effective if you don't have surgical capacity, but that is significant country infrastructure and is really not available to many people. And surgery is the first step, but without radiotherapy or chemotherapy to follow, that then makes it not clear whether that's how resources should be spent. It is a very difficult question here. It's a massive global inequity, and you really need, and that's why I don't teach most of the neuro-oncology that I know, because it's just not appropriate. Now, that's not right. It's terrible. But probably will never be for a long time one of the priorities in countries that are looking for low cost, high yield interventions.
Okay,
So that's not a very helpful answer. I'm sorry.
Oh no, it's fine. Just that some of us who are in the low income areas, and we can't afford such, like maybe surgeries or X-ray or whatever test. So I just want to know what are the low income interventions.
Yeah, I guess probably temozolomide chemotherapy then would be, it's tablets, it's not intravenous, but how well that works in the absence of the other things that go with it is incredibly difficult to know.
Thank you. Any other questions?
Someone's asked for my email in the chat, so I am just putting it in. I'm very
Perfect.
happy to be contacted.
Thank you so much for sharing your email with us, with everybody.
There's so much email in my inbox, there might as well be more. Just let it overflow.
Okay, so do we have any further questions? If not, then Shruti, you can go ahead and close us up.
Well, thank you so much, Dr. Drummond, for presenting so early in the morning and also answering all of our questions and being happy to take any questions further ahead as well beyond this talk. And thank you for our audience for joining today.
Thanks, everybody. It was fun.
Yeah, have a great day.
Dr. Drummond,
Bye-bye.
have a good day. And we will talk very soon.
Thanks. Excellent.
Thank you
Okay.
so much.
Bye.
Bye.
Thank you.
Bye.
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 Mhm.